Well, Croeso, welcome. And thank you so much to our alumni, staff, donors, friends, and supporters for joining Cardiff University today. As the note just said, our digital showcase is being recorded tonight. And tomorrow we'll send you a link of the recording, which you're very welcome to share. I'm TJ Rawlinson. I'm Cardiff University's Director of Development and Alumni Relations. And you're very welcome here tonight as part of the Cardiff community. You're welcome whether you are alumni, staff, students, or friends who support the university's learning and research. This evening, our focus is on the inflammation response, which causes arthritis, and how our research can help to find more effective, personalized treatments. So I'm really delighted that tonight I'm introducing two colleagues, Professor Simon Jones and Professor Ernest Choy. Simon is a researcher and Ernest is a clinician. Tonight we're going to hear about how important their partnership and collaboration is. Simon is, well, I'll introduce Ernest first. He's professor and head of rheumatology at the Institute of Infection and Immunity. He's also director of Cardiff University's Regional Experimental Arthritis Treatment and Evaluation Center in our School of Medicine. So he researches experimental medicine and clinical trial design in rheumatic diseases. He's conducted many proof of concept first in human clinical trials in inflammatory arthritis, particularly in rheumatoid arthritis. Simon is Dean of Research at the School of Medicine. He's Dean of Research at the School of Medicine. He's also Research Theme Lead for Infection, Inflammation, and Immunity. He's a professor of inflammation biology, and he has a global reputation in the field of cytokine biology. So welcome to both of them. Simon and Ernest will be presenting to us for just under half an hour. I've watched their slides and I think you'll be riveted. When they are finished, I will host a Q&A session. You're very welcome to enter any questions that you have as we go in the Q&A box, which is at the bottom of your screen at any point. We'll try to get to as many questions as we can at the end of the presentation. We'll finish tonight by 6:15. So I'd like to start with a warm welcome to Professor Simon Jones. Over to you, Simon.
Hello, well, thank you very much, TJ. Welcome everybody, it's great to see you all perhaps. I hope everything is okay with you all. So this evening, what I want to try and do is to provide information about the work that Ernest and I are doing in Cardiff relating to the control of inflammation. And I thought I would start by giving you a little introduction to the problem as a whole. Can I have the next slide, please, Caroline? So the kind of processes that we're really bringing to bear here is really trying to understand the mechanisms that are responsible for driving the pathology in patients who have rheumatoid arthritis. Now, this is a condition that's affecting about 700,000 people in the UK at the moment, and it's traditionally considered a disease of joints, particularly bones and cartilage within joints. And has a major bearing on patients' quality of life. And as we hear later on through Ernest's discussion, that this condition is not just a disease of the joints, but in fact is much more global than that, and has a major clinical impact on the way in which we manage patients. And as you can see from the bottom part of this slide, the actual socioeconomic burden that this disease causes is a considerable amount of money for both the NHS and also for economy as a whole. Can I have the next slide, please, Caroline? Thank you. So in Cardiff, what we're really trying to do is to deliver an integrated approach to understand how the disease process evolves. So thinking about the therapies that may be applied, disease is progressing, to try and adapt the way the therapies are used in these particular patients. So we take very much a combined approach, with Ernest being the clinical arm of the activities and myself being the fundamental scientist, to really understand the mechanisms that are driving the way in which the disease manifests itself. If we can really understand that, then we can perhaps introduce new diagnostic tools or therapeutic interventions that actually improve the quality of life for the patients. And ultimately, the overall ambition is to really prevent the disease from progressing to anywhere that's debilitating at all. Next slide, please. Now, you'll often hear this term bandied around as you go to your GP, and they'll say it's just a touch of inflammation and you take your ibuprofen and away you go. But effectively what we know is that inflammation is at the root of most of the diseases that are being treated commonly within the clinic. And it's a term which is very well misunderstood at times. And so I thought it would be important to introduce this at this stage. Can I have the next slide, please? Thank you. So the important thing to remember is that inflammation is not a disease, but it's a consequence of disease, and is actually there to try and protect us in some form. And the simplest way of thinking about that is by thinking about the pimple that develops on the end of the nose, and poor old Bill Clinton here has a massive one here. But what it's illustrating is the classical hallmarks of inflammation, which are always there and always present. And that includes evidence of redness and swelling, equally pain, and also heat. Now, importantly, in inflammation, as in a pimple, we know that we get these from time to time, but we also know that within 2 to 3 days, they resolve and they disappear. Now, the question is, how does that transition to something much more damaging? Can I have the next slide, please? So the important thing to remember here is that inflammation, or the processes that are linked with inflammation, are actually important for both our health and also for the development of disease. So for example, during healthy times, we know that these processes are having a major influence on metabolic outcomes. So perhaps looking after our glucose levels or the cholesterol levels that we see. Iron, important for anemia, for example, and looking after our red blood cells. We also know that it's important for the turnover of cells. So for example, generating new bone or the generation of new blood cells that need to be there in order to look after us as a whole. As we work through these particular processes, we can also see that it's important for looking after our mental well-being as well. And aspects including our sleep cycle and our fatigue are highly associated with mechanisms that influence the control of inflammation. Now, in terms of disease, what we know is that inflammation is set up to protect us. And we know that antibody generation and the way in which we memorize the way we've had previous infections is really important for looking after us. And obviously vaccinations is a kind of key area there, which is also timely at the moment, given our circumstances at present. But we also know it's important for repair and correcting, infection control and recovery from injuries. But in terms of disease, it's very much important in determining the outcome of that condition, whether we advance in terms of the disease or actually we improve in terms of the disease. Next slide, please, Caroline. Now, really what we're interested in, Cardiff, is understanding the decision-making steps that make that transition from health to disease. And in rheumatoid arthritis, we know that this is an autoimmune disease. And this is a term which is used to explain how that the immune system has actually turned against us. And instead of offering protection, is actually driving disease. We know that various triggers are responsible for that, and that can be environmental factors such as smoking, or it could be genetic susceptibilities, a prior infection incidence, or even conditions like obesity can have a major bearing on the outcomes of conditions such as rheumatoid arthritis. Next slide, please. So the areas that, so I'm going to hand over to Ernest at this point, who will introduce the biology behind some of the therapies that are currently used.
So, thank you, Simon. So it's a privilege for me to work with Simon for many years, and Simon has been educating me about cytokines, particularly the cytokine interleukin 6. And because of that knowledge, about 12, 13 years ago, we started to do a clinical trial of a monoclonal antibody that blocks IL-6 and gave it to patients with rheumatoid arthritis, and actually found that it was very effective. And over the next few years, we're able to, in collaboration with pharmaceutical companies, develop this treatment. And eventually it was approved for the treatment of rheumatoid arthritis 10 years ago. From then, we found that not only this treatment is effective for treating rheumatoid arthritis, it is also effective for treating children with inflammatory arthritis, a condition that we call juvenile inflammatory arthritis. So that's all good and well. And as we were learning a lot more about this treatment, we started to trial it in other conditions, including giant cell arthritis, which is a condition causing inflammation of the blood vessels, and also conditions that causes generalized inflammation, a condition that we call adult onset Still's disease. Now, in this condition, patients get very, very high fever, they have a skin rash, and the patient becomes very sick. So what this together tells us is that interleukin-6 as a cytokine is not only important in causing local inflammation in the joint, but is able to cause inflammation around the body, blood vessels, the liver, the brain, causing many of the systemic manifestation. Actually, as a result of that knowledge of how IL-6 is very important in systemic inflammation, earlier this year, the IL-6 inhibitors were used in patients with COVID pneumonia because a proportion of this patient get very severe systemic inflammation. And it shows how the basic biology has led us to more effective treatment for many chronic inflammatory conditions. One of the conundrum in this development approach is that whilst many patients benefit from treatment, some patients don't respond, and we still don't understand why some patients got better while others did not. And this, we have to go back to the basic biology to find an answer. Simon.
Next slide, please. Thank you, Ernest. So Ernest has introduced there some very detailed scenarios which are affecting the way that he uses clinical management tools to combat the disease of rheumatoid arthritis. So we have to go back a step now to really reintroduce some of the thought processes that allow him to make choices on the types of therapies that he uses. Now, if we think about the inflamed joints, and here's a kind of a picture of what really happens, is that we know that there will be cells which are structural to that particular joint, and they make sure that our knees bend in the correct way, for example, or our hands flex in a particular way. But during diseases like rheumatoid arthritis, these areas become inflamed with immune cells becoming part of that process. And so what happens here is now that there is a communication, if you like, between the cells which are local to that particular joint space and the immune cells which are being called into action to deal with a problem or condition that's arise because of that. Now, obviously, this is a very complex interaction, and we're going to zoom in now on particular aspects of that to try and see how the inflammation is controlled and initiated. The next slide, please, Caroline. So here we are now, we're zooming in onto that area and thinking about that communication between the immune cells and the structural cells. So we're thinking about how the environment senses and interprets decisions that make sure that the disease progresses in a particular way. So the way in which this happens is through a series of proteins which are called cytokines. Now, these cytokines are obviously outside the cells. They sit in the fluid, for example. And if you imagine, they could be like that kind of bat signal that gets sent up into the sky when there is an issue or a problem. Now, in order for that to be interpreted, there has to be ways in which the cells sense these kind of cues, and they use receptors, a bit like a telephone, if you like, to dial in for information about what the environment is telling them. And then, of course, from there, then Batman picks it up, he gets the signal, he knows how to respond in the correct way. But the key problem here is that he doesn't always respond in the right way, and may actually cause more problems than actually trying to solve. Next slide, please. And as a consequence of that, what we then know is that we then can understand that these cytokines are really instrumental in determining the progression of the disease, perhaps the severity, how long the disease progresses for, and actually, as Ernest alluded to, the influences that are having on the kind of mental well-being and the wider profile of the patient that we're actually looking at. Now, as a consequence of the biology that we understand about the role cytokines play in diseases like rheumatoid arthritis, we now have a range of therapies which are used to combat these particular agents at particular levels. So some work directly on the cytokine itself. Others work on these telephones, the receptors, which are positioned on the surfaces of cells, immune cells and tissue cells. And we also have blockers which look after the signals which are transmitted inside the cell, which influences the way the cell then responds to those cues externally. Now, the drug that Ernest introduced and was very much involved in the clinical development of is called tocilizumab. And we've kind of used our biology around this particular molecule and therapy to examine how this system then engages to promote disease activities. Next slide, please. Now, the important thing here is to understand when to commence treatment. And what we want to do here is to understand the inflammatory cues which are triggered very early in the disease process. The earlier that we can commence therapy, the less likely we are to develop those telltale hand signs that we see in late stage disease with the detrimentally damaged hands and joints. If we can understand those cues, those checkpoints, which initiate that inflammation to progress and then drive these kind of changes in the architecture of the joint, then we may be able to better prescribe interventions. The question, as Ernest alluded to, was who will do best on what drug? And there has to be appropriate. That therapy has to be the right therapy for that particular patient. And that is the basis of this precision medicine. So in order to utilize that kind of approach, that strategy to treatment, we have to understand the diagnosis. How do we inform the diagnosis? How can we then get early predictors that will give us an idea of the course of the disease? And how can we then use those combinations to inform the therapy and enhance the opportunity for treatment? Next slide, please. So, as I said, choosing the best therapy is very difficult and is very complex. And one of the main reasons behind that is that not all patients experience the same form of disease. So how do we know that? Well, advances in precision medicine include the use of ultrasound methods, a bit like scanning a pregnant woman when you're trying to monitor the baby. You use an ultrasound to monitor the hands and joints. From here, you can actually take biopsy samples, and then you can look down the microscope at the way that disease is established. Now, importantly, what we know, and I've got 3 examples here, is that there are various forms of disease that individual patients experience. There are patients within these 3 groups, but equally there are patients that sit between these groups. So the disease is what we call very heterogeneous. Now that raises some really important questions, and they are fundamental to the work that we're doing in Cardiff. The first thing is that what are the mechanisms then that determine what type of disease you get? How does that influence the severity and duration? And how does that then influence the treatment decisions that we make? Next slide, please. So what we're trying to do here in Cardiff is to really look at those checkpoints, those within the cytokine system that give rise to these particular changes in the course of disease. So what are the gene mechanisms that are being controlled inside cells which influence the way the pathology or disease is presented within the joint? So it's a bit like understanding that communication between Commissioner Gordon and Batman down the phone. Next slide, please. So to do that, what we're using is big data approaches to look at the control of genes within individual patients that have rheumatoid arthritis. By doing that, what we can actually do is compare patient groups individually against very set criteria, which might be their disease severity, which is a DAS-28 score. It doesn't really matter, but it's about the severity of their disease, or against markers of the pathology that we actually see down the microscope. Equally, we can use this information to track biologic responses to particular drugs, or to even dissect the pathways and mechanisms that are responsible for driving those particular conditions in a particular patient or a particular patient group. Next slide, please. So to simplify this, what I've done here is I've focused down onto one particular cytokine, which is called IL-27 or interleukin-27. Now, working with Ernest and colleagues in London, what we were able to do was identify patients that had two different types of disease presented within their joints. Now, importantly, one of those particular patient groups had a low level of IL-27, while the other one had a very high level of IL-27. And by monitoring those particular markers, we can then perhaps think about ideas for appropriately stratifying those patients according to their disease based upon IL-27, and perhaps look at tailoring therapies that would then engage that particular pathology in a much more sophisticated way. Next slide, please. Now, of course, we can also extend this and we can bring in studies that involve mice. And the reason why we do that is because now we want to understand how a molecule like IL-27 may contribute to the disease. And we can work between human and mouse samples to really get an idea of the mechanisms that are actually contributing to the pathology. Now, that is very important because not only does it open new opportunities for therapy, but it also gives us opportunities to think about how we can better apply existing therapies in that particular space. And that's important for terms of looking at diagnostic indicators, how we group patients according to their pathology, the so-called stratification of patients, and as I said, thinking about therapies. So many of the approaches that we are adopting in human particular pathologies, as I showed you earlier, can equally be applied to mouse settings. So we can use what we call reverse translation to actually get a much more fundamental understanding of the disease process as a whole. Next slide, please. I'm now going to bring in Ernest, who will kind of explain how that particular relationship may work in a kind of a clinical context. Ernest, please.
As a clinician, what Simon shows is really exciting because as a simplistic level, what it is saying is that we have one diagnosis, rheumatoid arthritis, but if we look inside the inflamed tissue, we see different pathology, different genes, so they're different biologies. And in fact, through works that Simon has done and others, we are seeing the same pattern in animal models of different inflammatory conditions, and also inflammatory bowel disease, psoriasis, many chronic inflammatory diseases. So building on these observations, we have formed a consortium across Europe, and we've been funded by the Horizon 2020 European Union grant to see whether we can move away from treating disease, but treating underlying pathology and genes. So if we look at the inflamed tissue and understand what may be causing inflammation in that diseased tissue, can we use specific treatment for that pathology rather than relying on the conventional disease-based diagnosis treatment? And the collaborators are shown on this slide. Aside from locally in Cardiff, we have many experts in clinical trial designs that will help us to do that. We're collaborating with Germany, with Spain, and with Italy to have a European consortium to try to tackle this issue. Having said that, this kind of approach is very important for precision medicine, but it doesn't answer all the questions that we talked about before, which is the inflammation is not only limited to the joint or inflamed tissue. So this will only address the question is, what is the pathology that drives disease in the inflamed tissue? What we don't understand is how does the local inflammation cause all the other manifestation associated with these inflammatory diseases. Simon, next slide, please.
Next slide. So that's exactly right. And as Ernest says, in his clinical context, he's experiencing patients that not only have inflammatory arthritis or rheumatoid arthritis, but they also display other forms of pathology. That may be cardiovascular disease, for example, or impacts that affect their fatigue or mood. Pain is obviously a massive, massive component of that, and also metabolic conditions. But, these types of areas are really fascinating. And from a mechanistic point of view, why do people experience these types of multimorbidities, as we call? These are individuals that have one primary condition, but may have 2 or more, sometimes up to 8 different pathologies running within them at the same time. Now, obviously, these are having an extremely detrimental impact on their overall quality of life and the way in which they are prescribed medications, often resulting in what we call polypharmacy, where patients are receiving multiple drugs for multiple different conditions. So this is an extremely complex clinical management. So now some of the newer and more exciting areas of research is to try and understand how all of these processes are connected. What connects the inflammation in the joint with the inflammation that runs and affects all these other conditions? Are they linked? Are they different? What is the manifestations that direct that? And I think these are really important questions, which will be for the next 10 years or so, which will be an important aspect of looking at the long-term clinical management of these patients. Ernest, perhaps you can kind of explain a little bit more about, the types of conditions that you're looking at in the clinical setting.
Thank you, Simon. Next slide, please. So as Simon said, this increase in comorbidity or multimorbidity in rheumatoid arthritis is now a hot topic, if you like, in research. And a couple of years ago, the European League Against Rheumatology led a consortium effort to look at this issue. So this is a paper published a few years ago looking at all the different comorbidities in patients with rheumatoid arthritis. You can see that there are cardiovascular disease, malignancy, skin disease, asthma, chronic obstructive airway disease, diabetes. All of them are fairly common, but surprising to many people was what was shown on the right-hand side. The most common comorbid condition is depression or mental issues. So that raises a lot of questions on why would patients with rheumatoid arthritis have such a high prevalence of mood disorders. Next slide. Now, there's this hypothesis that perhaps one of the reasons is that rheumatoid arthritis causes painful inflamed joint, and when your joints are painful, then your mood becomes low, and that affects your sleep quality. And because of these, you feel very tired, and when you're tired, then you are unable to cope with the pain, and that leads to a rather vicious cycle that causes more severe pain. Next slide, please. Now, there's some support for this hypothesis because last year there's a cross-sectional survey conducted in patients with rheumatoid arthritis, asking them what are the major areas of unmet need in terms of their treatment, which is shown by the light gray bar on this slide. And you can see that fatigue, sleep disturbance, pain, and psychological well-being, as well as coping, are all highlighted by patients as area of unmet need. So these issues seems to co-aggregate in individuals, and so it may be linked together. Next slide, please. So in order to understand this issue more, a couple of years ago, one of my students looked at pain in patients with inflammatory arthritis. And what she found was that the pain is not the same. Interestingly, there's a specific pattern of pain in the most severe patients called neuropathic pain. So neuropathic pain is typically a kind of pain that occurs in individuals who either have damage or inflamed nervous system. And you can see the patients with characteristic of neuropathic pain tend to have higher number of tender and swollen joints. They have more pain, they are more likely to be tired, and they are more likely to suffer from depression. So all the symptoms that we talk about seems to be associated with these special features of neuropathic pain. So the question is, why should patients with rheumatoid arthritis get neuropathic pain? Next slide, please. So here's a hypothesis that we built after publication of that paper. So we know that inflammation, as Simon said, leads to the release of cytokines such as interleukin-6. And in patients with very active inflammation, we can find this cytokine in the circulation. So IL-6 can be found in patients with very active rheumatoid arthritis. Now, IL-6 is a fairly small molecule. It can leak from the blood vessels into the brain tissue, so it may have an impact on the nervous system. The treatment we use to block cytokines, the monoclonal antibodies, are much larger molecule. So as shown on this slide, the monoclonal antibodies are about 6 times larger than the cytokines themselves. So whilst the cytokines can leak to the brain, the monoclonal antibody will stay in the circulation. So if the cytokine leaks into the brain and have an effect on the brain, that it could lead to the fatigue, the depression, and the increased pain perception. But the monoclonal antibody won't able to affect this effect of cytokine in the brain. Now, the challenge to look at this hypothesis is that whilst we can biopsy the joint, we couldn't really biopsy the brain. So we have to rely on a different technology. Next slide. So what is fortunate in Cardiff is that we have one of the best neuroimaging center in Europe called CUBRIC, which stands for Cardiff University Brain Research Imaging Center. It was opened by the Queen a number of years ago. And in a single building, it housed multiple advanced neuroimaging facilities. And it actually has one of the largest MRI scanner in Europe at 7 Tesla. And to put that in context, the conventional MRI scan in everyday clinical practice is about 1.5 Tesla. So 7 Tesla is about 4 times the size of a conventional MRI scan. And that allows us to see very detailed picture of the brain. And in addition, these scanners have extremely fast camera to take rapid images in quick sequences. Now, why is that important? Next slide, please. Because actually, for the last 10 years, we have used MRI scan, particular functional MRI scan, to look at pain experience in patients with rheumatic disease. And these scans allow us to see brain activity. And you can see on this slide, when brain become active on the scanner, you can see activity as depicted by different colors. So the hotter it is, or the redder it is, the more active the brain is. Now, this kind of image straight away tells us that the pain experience in the brain is very complicated, because you can see many, many different brain regions are being active. Some of them become hotter, some of them become less active, which is shown in blue. So these are all very well. This tells us that the pain experience is complicated. We understand that different brain regions are involved in those experiences. But what we don't understand is how these different regions work together to cause pain. So to do that, what we need to do is to use the latest technology to understand how these brain regions work together. Next slide, please. And this technology is called a connectome scan. So as I said earlier, at CUBRIC, they have one of the largest magnet. And what that allows the image to do is to look at individual nerve bundles and track them together in the brain. And by having a very fast camera, you can look at which region of the brain is being activated first, followed by another region. So you can actually see how the different brain regions are connected together and highlight this with different color. So you can actually see the individual brain tract and how they get connected together. So this technology is called the connectome scan. And this is a video to show and illustrate how the scanner would demonstrate results. So first of all, you can see the different tract of the brain is highlighted by different scanner. And using high power computer modeling, you can actually turn the brain around 360 degrees, and you can remove certain tracts to reveal underlying brain region and pathology, and you can see how they work together. So you can see the image is very impressive, but even more impressive is it allows us to assess in real time what the pain experience is individual patient. And at least some of the preliminary work we have done have shown that there is some issue with connection in the brain in the patient with the most severe kind of pain. So next slide, please. So I think what Simon and I have hoped to convey to you is that right from the beginning, by working together, we have dissected out how cytokine leads to joint inflammation, and that has led us to develop new treatment for patients with rheumatoid arthritis. And that is good, but what we know is that although the clinical features in patients with rheumatoid arthritis are similar, inside the joints, different genes and proteins that drive inflammation are different amongst patients with rheumatoid arthritis. And this different profiles offers hope of personalized medicines in the next 5 years. Now, the effect of inflammation in rheumatoid arthritis is not limited to the joint, but many parts of the body, including the central nervous system. And it causes pain, fatigue, depression, and sleep disturbances. And these are the areas of unmet medical need in the treatment of rheumatoid arthritis. And we continue to collaborate between basic and clinical scientists in Cardiff, and supported by some of the cutting-edge technology, including Kubrick, to help us to address these unmet medical needs in the future. So I hope this discussion is of interest to you, and Simon and I are happy to answer any questions that you may have.
Well, Ernest, Simon, that has been fantastic. Thank you both so much. It's really clear that the partnership between Simon as a researcher and Ernest as a clinician is very fruitful, really important. I'll give our audience a reminder that you can enter questions in the Q&A box below. We've also had a few questions that came to us prior to the event. So I will start with some of those. And if you'll pardon me while I get my questions up, there we go. So the first one is around understanding, well, one that's just come in actually is Greg from Cardiff is interested to hear about how your understanding of basic biology has fed into COVID-caused pneumonia treatment. And he's asking whether either of your research has directly fed into the pandemic response in any way.
Okay, so shall I take that question, Simon, first? So actually, one of the work that Simon has done is to show that IL-6 is very common in patients with very severe inflammation. So actually what is interesting with COVID is that it's a little bit like rheumatoid arthritis. So everybody knows that some people have very minimal disease, but some people have very, very severe disease. And some of the patients with the more severe disease have what we call a cytokine storm. They have lots of cytokines in the circulation, and people have measured IL-6 in the circulation, and some of the more severe patients has huge amount of interleukin-6 in the circulation. And that was the reason why some of these patients have been treated with the IL-6 inhibitors that we use to treat rheumatoid arthritis. So that is really based on our understanding about IL-6 biology. Simon, do you want to add to that?
Yeah, thank you, Ernest. I think that what we're really getting an appreciation of is that inflammation is affected in both infections, viral infections, bacterial infections, as well as in these kind of autoimmune diseases like rheumatoid. And actually what we're knowing is that, you know, the way in which we apply the therapies in all of these settings may be beneficial for some patients, but for others. And I think that what we're actually seeing is that, you know, it's advancing our way of thinking about the way inflammation is set up and the way that it's working. I totally agree with Ernest. You know, the biological drugs that we're now using are going to be major players going forward. And it's giving us some real insights into the disease.
That's really helpful. Simon, just so you know, your sound just went a little squirrely for me. I don't know if something's sat in front of your microphone now. Hopefully it'll improve because it's been great up to now. I have another question here that I've seen, but I'm not sure either of you have, which is that it's exciting to hear that you're working towards personalized medicine. How close are we to the scenario where my doctor will do a simple test to identify my personal pathology of rheumatoid arthritis and then tailor my treatment with the right drug for me?
Ernest?
Well, I hope 5 years. That's my guesstimate. I may be optimistic, but I hope 5 years. I mean, I think if we can finish our European study and show that that approach is effective, then we probably would have found the right sort of gene protein signature.
Yeah, I think that's true. And there are now, you know, really cutting edge technologies which are being applied, which look at the disease at a very single cell level. And I think that what we're seeing there is a lot more sophisticated analysis as the processes that are involved. And this will tailor our thinking very much going forward. I think at the moment, what we've got is a situation where if a patient is part of a clinical trial, we can be very specific about, you know, classifying them into a particular type of disease. But for a lot of people, they don't naturally sit within those defined criteria. And I think that is our challenge for the precision medicine. How do we combat or treat those particular patients with the correct identification tools?
Well, that's a helpful lead into a series of questions that we received prior to the seminar, where people were asking about particular ways that they might help support treatment of their arthritis diagnosis. So they're looking for prevention tips from you, whether there are studies that you particularly rate about diet or the benefit of yoga or Pilates. What actively could people who are watching this seminar now do to help manage their own disease progression?
Okay, well, maybe I'll take that. So I think actually it's very interesting. So I think actually one of the most important thing is that to stop smoking if you're a smoker. Believe it or not, the rheumatoid arthritis is an autoimmune disease, but actually the autoimmune process does not start in the joint. It actually starts in the lung or the oral mucosa. So if you have poor dental hygiene, that is another risk. So what really happened is that the development of the autoimmune disease is a combination of genetic factor and also environmental influence. So if you have certain genes, it gives you a certain type of immune profile, and that profile makes you prone to react to certain protein called citrulline. And citrulline is produced in the lung, especially in smokers, because it's induced by smoking, and by certain bacteria in the oral mucosa. So you have poor dental hygiene, you allow bacteria to grow in your mouth, it causes more citrulline. And when you have the citrulline plus the right genes, it changes your immune system and make you prone to develop arthritis. So those are the two things that we definitely know. Would diet help? We don't know for sure. We certainly have students who are working on dietary factor that may reduce, say, cytokine production and inflammation. The current data was suggested that it has some effect, but we probably need a combination of this effect to have a significant impact.
Well, I have to say, oh, sorry, Simon, go ahead.
And I guess, anything that improves your mental well-being overall, in terms of managing your condition as a personal kind of perspective, is obviously going to be beneficial too.
Yeah. And actually, it reminds me, when Simon speaking, it reminded me one of his work to show that actually, when you exercise, it actually affects your immune metabolic responses. And actually, exercise is very important to have a healthy immune response.
So things like interleukin 6, horses run slower when you inject them.
Yes, exactly.
Both Simon and Ernest, I think we've promised people that we would finish at 6:15. I would love to carry on, but I think we do need to bring this to a conclusion. Please rest assured that if we haven't had a chance to answer your question, or if you'd like to send anything in for Simon or Ernest following this event, we'll be glad to follow up with you personally. It's exciting for me that more than 50 people have joined us over the course of this event. So I wish that we could have done this in person, but it's exciting that we've managed to do it in this virtual space. A huge thanks to Professor Simon Jones and Professor Ernest Choy for sharing your work. Very warm thanks to you, our webinar audience, for joining us. It's really clear that amazing research that's going to have a personal impact on a lot of us is taking place at Cardiff University. If you would like to support us or find out more information, we'll pop a link in the comments box below. We also have a program of events coming up. So for instance, on the 22nd of October, we'll be looking at how Cardiff stem cell work could inspire effective treatments for breast cancer. But anyone who's been with us tonight will receive an email tomorrow with a copy of the recording of tonight's event. Please do share that, and links to register for upcoming events. So we really hope that we'll welcome you back again soon. Once again, Simon, Ernest, thank you so much. And to our audience, diolch yn fawr.